I'm going to teach you guys a little bit about multiple myeloma today. So what is it? Multiple myeloma is basically a B-cell cancer that is characterized by basically what happens is malignant plasma cells proliferate and then infiltrate the bone marrow, and then they form tumor masses throughout the whole skeletal system. So this occurs in about 5 out of every 100,000 people in the United States. It occurs about twice as much in blacks as it does in whites, but it does occur in all races. And it usually occurs around age 70, but rarely before age 40. And it's slightly more common in men. So basically what happens is that neoplastic cells of multiple myeloma reside in the bone marrow. And they're usually not found in the outside blood, but occasionally they can spread to other tissues, especially if the disease is advanced. So basically the defect here is genetic, and it may result from chronic stimulation of B cells with bacterial or viral antigens. So we'll go into more detail. So the pathophysiology behind what's occurring here is that most of them involve translocations in the chromosomes, so breakpoints between chromosomes. They also involve proto-oncogene mutations as well as inactivation of tumor suppressor genes, but that right there is a little bit more, it's more rare than proto-oncogene mutations. Basically, one B cell alone, as you can see over here, produces malignant plasma cells. Not normal, malignant, and there's usually abnormally large amounts of one immunoglobulin, usually immunoglobulin G, and it may begin early in B-cell development. So myeloma cells then return to the bone marrow or the other soft tissues, and cell adhesion molecules help them to target favorable sites, which allows them to expand and mature. And then cytokines, particularly interleukin-6, promote growth and survival of multiple myeloma cells, which we'll see here. So the myeloma cells in the bone marrow produce the cytokines. Interleukin-6 stimulates the osteoclasts, which then reabsorbs the bone and leads to bone lesions and hypercalcemia because the calcium is being released. So basically an M protein is an antibody that's produced by transformed plasma cells that are frequently defective. And so those defects include truncations, deletions, and other abnormalities. So because there are so many malignant plasma cells, we find an increased amount of M protein in the blood, and it's the most prominent. And as well, normal protein or normal plasma cells are suppressed, which leads to a lower amount or possibly absent amount of normal antibodies. So then if IgM is the one that's produced, we have an excessive protein weight since IgM is so big. And that leads to higher blood viscosity. And oftentimes we find the free immunoglobulin light chain, so that's the short little portion, which is called a Bence-Jones protein, and that's often present in the blood and the urine and can lead to renal tubular damage. So clinical manifestations, what this shows is that you have hypercalcemia and bone lesions as well, which occurs because the malignant plasma cells infiltrate the bone, and then that stimulates the osteoclasts, which reabsorb the bone. We talked about that. Renal failure can be acute or chronic, which is actually secondary to the hypercalcium, which we said occurs because the calcium leads into the renal tubular failure, as we saw down over there. So then anemia can be normocytic and normochromic, which is usually caused from a decrease in erythropoiesis by tumor cell infiltration of the bone marrow. And you usually feel pain and pathologic fractures because the bone tissue is being destroyed. Most commonly occurs in the vertebrae, the ribs, the skull, pelvis, femur, clavicle, and scapula. In about 90% of cases, we see proteinuria, and in about 80% of cases, we see the Bence-Jones protein, which again may damage the renal tubules. So if you have high serum paraprotein in your blood, that basically means the abnormal antibody with the defects. You can find hyperviscosity, which then can interfere with the blood circulation to your brain, kidneys, and extremities. And that IgM paraprotein may lead to cryoglobulins, which are basically just proteins that when there's a temperature lower than body temperature, they will precipitate from the blood. Those hypercalcemia and hyperviscosity may then lead to other neurologic symptoms such as confusions, headaches, and blurred vision. The immune system response, the humoral response, is basically being suppressed. So that leads to us finding more infections most commonly by bacteria that are encapsulated and are sensitive to the antibody effects, such as Streptococcus pneumoniae, Staphylococcus aureus, Klebsiella pneumoniae, which then lead to pneumonia, and then E. coli and other gram-negative organisms can lead to pyelonephritis. Those are the most common. T cell function is normally pretty normal, and then the leading cause of death from multiple myeloma is overwhelming infection. So to evaluate this, we find for diagnosis, we can base it off of the symptoms, or we can do radiographic and lab studies, or a bone marrow biopsy as seen here. This will show, basically it's an x-ray which shows the multiple lesions in the bone. You can also do quantitative measures of immunoglobulins, which will show increased M protein. You can look for Bence-Jones protein through these methods here, or you can measure the beta microglobulin, which will indicate how effective the therapy is going. To treat this, we can do chemo, which can improve the prognosis, how long the person will live, but if they relapse after conventional chemo, we can give them thalidomide. We can also do radiation or marrow transplant, but autologous peripheral blood stem cell transplantation is preferred, so a picture of that kind of is shown up here. Basically, that's the mechanism used. We can also use corticosteroids or bisphosphate therapy for bone lesions, but if we have multiple bone lesions that go untreated, people will rarely survive for more than 6 to 12 months. Regardless of the treatment options, though, even though we have all of these options, prognosis still remains pretty poor. And but if a patient does have inactive myeloma, they can survive for many years. So these are my references, and I hope you enjoyed my presentation. Thank you.